Alrighty, so in the interest of time, because we have a very packed schedule today, we'll go ahead and get started as folks continue to roll in. Thank you all for joining us today for our final session of our three-part Congenital Syphilis series put on by the National Coalition of STD Directors, or NCSD. My name is Talia Parker, and I'm the Manager of Program Operations with NCSD, and we're very excited to have you all here today. Today's session will focus on testing and treatment. And we're very excited to welcome some folks from, we have LAs today all over. So we have Los Angeles and Louisiana, and then Jeff Tobias from Diagnostics Direct as well. So before we get started, I just am going to go through some housekeeping. So as you can all see, we're using a meeting format, not a webinar. So we ask that you all stay on mute so that our presenters can speak without any interruption. There will be an opportunity to speak with your fellow attendees in the breakout rooms at the end of the session. And we encourage you to use the chat to speak with other attendees before then, and also to put your questions. These sessions are recorded, and we'll be sharing all three of them in the coming days. So you'll be able to share with your colleagues who might not have been able to attend. And finally, I just want to remind you all that there will be a brief evaluation at the end that I encourage you all to complete to share your thoughts about the sessions as well as future ideas for NCSD. So without further ado, I'm going to introduce our first speakers, and we'll get started. So from Los Angeles, Shobita Rajagopalan, pronounced she, her, hers, is the STD Controller and Associate Medical Director at the Division of HIV and STD Programs for Los Angeles County Department of Public Health. Shobita is a board-certified internist and infectious disease specialist with a Master's of Science and a Master's of Public Health from Charles Drew University and UCLA School of Public Health, respectively. Her interests include enhancement of clinical, educational, and research collaboration with community partners to improve public health outcomes. And Becca Cohen, whose pronouns are she, her, hers, is an HIV clinical specialist and associate medical director at DHSP LAC DPH. It's a long acronym. Becca is a family medicine physician with an MPH degree from SUNY Downstate Medical Center in Brooklyn. She also completed an HIV fellowship prior to joining DHSP. Her interests include LGBTQ health and working with justice-involved populations using gender-inclusive and harm reduction models and approaches to care. And I also want to note that Monica Munoz and Melissa Papp Green were also on the LA team but could not join us today, but we are very grateful for their work on this project and this presentation as well. So I'm going to go ahead and share my screen, and let's see, Shobita and Becca, you can take it away.
Thank you, Talia, and thanks everybody. We're excited to be here in our first presentation. I'll start the presentation and I'll turn it over to Becca to continue to complete the presentation. So again, our presentation is entitled Expanding HIV and STI Testing in Non-Traditional Settings. And we actually added a treatment arm to this. And our project is called Prevention and Outreach to Women at Elevated Risk for HIV and Syphilis, aka the POWER Project. Next slide, please. I wanted to start out with this slide because it does give you a good sense of intersecting epidemics with both HIV and syphilis. And you could see that if you look at 2020, there were 4 cases of perinatal HIV, which was way above the baseline. And we all know that this is has been a success story for years in preventing transmission of HIV to mom to babies. And unfortunately, we also noted that 3 out of those 4 cases also had congenital syphilis. So just to bear in mind that it's important for us to keep both of the HIV and syphilis in mind when testing and evaluating pregnant moms. Next slide, please. So I just wanted to share with you this continuing increase in rises in congenital syphilis cases and early syphilis, of course, in cisgender women and newborns in LA County. all the way from 2009 to 2019, and we haven't seen a dip. And 2020, which was the year of our pandemic, we even then, where we saw an artifact in decreased testing and reporting, we still saw that rise of 113 cases increase from our 88 cases the year before. And actually in 2021, the numbers are up to above 120. So this is clearly a crisis, and we're not making a dent in it. Next slide, please. So this is a small subset of our congenital syphilis cases in LA County from 2019. And as you can see, the breakdown shows 36% of those moms had a history of incarceration, 40% had unstable housing, 68% had substance use disorders, 49% were using meth or a drug combination with meth, and 80% of deliveries resulted in DCFS or foster care referrals. And if you look at the entry into prenatal care, the first trimester, second trimester, and third trimester had about 18% to 22% respectively in each of these groups of this group of moms. And then you could see that there was a pretty high proportion of those that did not enter into prenatal care, and there was an unknown group as well. And so this actually is, it's very eye-opening to where we may have to put our efforts on. Next slide, please. And this we just wanted to share with those of you who are not familiar with LA County. It's huge, and we have a lot of, a lot of areas. We actually call them service planning areas. And what's in red here really, it shows you the female syphilis in cases by the service planning areas and health districts by treatment status. And red is where the mothers were not able to be found, and either for whatever reason they were unable to be located. And you could look at central area, which is the downtown LA area, the metro area, is where we had the vast majority of these of the numbers, followed by our south central Los Angeles, which also has quite a high burden of displaced populations, especially people experiencing homelessness. And just to share with you that LA County has about 60,000 people experiencing homelessness, of whom 35% of them are cisgender women who can also become pregnant. So our target should be, if you're looking at upstream ways to control this, would be to target those populations and go and figure out ways that we can actually bring the care to these individuals rather than expecting them to come to us. Next slide, please. So what is it that sparked this non-traditional testing and treatment is the data and field experiences that we found demonstrating increased number of pregnant women of childbearing age and cis women with syphilis that are in persons experiencing homelessness and receiving no prenatal care. And so what we did was in May of 2019, our office, our staff were invited to join our Los Angeles Health Homeless Service Authority, known as LAHSA. They have wellness events all the time, and this one was one in the San Fernando Valley, which is called Spa 2. And we also partner with LAHSA. We partner with LAHSA to perform monthly wellness checks for these encampments in these target areas. Next slide, please. So we developed an approach to join the LAHSA team for these PEH outreaches. And one of the models we developed was a combined combination of a provider and an RN team to do field delivered testing and treatment. And we actually used the TrepSure testing, a rapid test in the field. And also we also included the venipuncture in the field if we could, and also offer other services like Hep A and B vaccinations, and offer STI prevention and treatment, and transport to a county clinic or hospital for additional services as needed. And there was a lot of preparation that went into play, of course, is training and signing off how to perform the TrepSure testing in the field, and review of procedures, policies, protocols, and creation of a field delivered therapy record. And we also obviously gathered all our supplies with educational materials, consents, testing equipment, medicines to take in our backpacks, chairs, snacks, drinks, and other types of incentives, and privacy screens in the trunk of a car. And I'll show you a picture that Monica actually put in on her slide. LAHSA is actually really helpful in gaining access to camps and acceptance with various with services offered, because there is a paranoia in people about public health coming to them directly. So we have to go really with our LASA colleagues and other partners who've developed a great relationship with people who are displaced in these areas. Next slide, please. So here's this is the couple of outreach efforts that happened in 2019. We did, there were three encampments in near the Regency Theater, Lancashire, and Pacoima Freeway underpass. And so we visited 3 encampments, and the outcomes of these were that we found 4 women of childbearing age, cis women, 1 pregnant woman, 3 refused any service, 2 agreed to rapid syphilis tests, of which 1 RST, she refused venipuncture, but she was positive. And we were able to give 2 Bicillins weekly intervals with incentives, but the 3rd one, she was lost to follow up. And the 3rd, the 1 pregnant person that was really did not want public health at all involved with her. She accepted LASA's outreach worker service to take her to an OB appointment and engaged in a program which is called Mamas, which actually provides housing as well as services for prenatal care. And it's through our sister agency, Department of Health Services, at a county medical center. So that was good. Some of the challenges we noticed in this initial outreach was that the RST is difficult to sometimes difficult to do because it does have a pretty large lancet. And in people who have calluses on their fingers, it's really hard to puncture the tip of the finger. And also additional venipuncture is difficult to do in the field because they may have collapsed veins, may be dehydrated. And the weather conditions, also strong Santa Ana winds, make it difficult. And this is a setup in Monica's trunk of her car when they went out to the outreach with a lot of educational materials, a little bit of like a little clinic in the back of her trunk. And then, they used a wall to be at one of the privacy walls and then the privacy screens. Next slide, please. So before we go on to this, and this is actually where I transition over to Becca, is that also in addition to that particular outreach that was done to the encampments, we started to develop some survey of homeless services providers in the Metro Skid Row area of downtown LA, which has a concentration of people experiencing homelessness, and also a concentration of medical and other services provided, and street teams and resources that are in that area. In our survey, we found 2 federally qualified health centers that came through willing to partner with us to do syphilis testing, rapid syphilis testing, and full blood draws, as well as partnering us with treatment. And one of them actually did form a really great partnership. It's called LA Christian. That's going to be brought up in a few minutes. And they were actually willing to do the RSTs, do the blood draws, and then provide us data. And that also helped us kind of talk about this power project, sort of build into the power project in terms of experience and what data they could share. So with that, I'm going to turn over to Becca to continue on to tell us a little bit more about the project and outreach. Thank you.
Thank you, Shabita. Thanks everyone for having me here. So this next section is about the power project that we started in 2020, sort of building off of the experience that Shabita covered in 2019 with our smaller outreach to those encampments and the work that Shabita was referencing to our partnership with an FQHC in downtown Los Angeles called LA Christian Health Center. So we were, as part of the Power Project, we wanted to identify non-traditional sites for syphilis and HIV testing and treatment among cisgender women of reproductive age who were experiencing substance use disorders or mental illness. And so we were looking to, assess for feasibility, acceptability, also finding, high prevalence, areas to focus on and what would be sustainable. So our first step, we did a series of key informant interviews, and this list just demonstrates some of the different programs that we reached out to and talked to about this work. And so with the next slide, you can see that we ultimately ended up, if you could switch to the next slide. Thank you so much. Deciding to develop a partnership and build a program around some of the work we were already doing with this organization, LA Christian Health Centers in downtown Los Angeles. So this slide just shows you some of what they already had in place through a partnership with us. So that mobile testing unit is a Department of Public Health van that we developed an agreement for them to use it on a weekly basis, and focus on the point of care syphilis, HIV, and Hep C testing. Basically the testing's available to anybody who wants it, but they definitely are aiming to focus on cisgender women of childbearing age with this activity. So we knew that they were down there doing this work, once a week. And we were kind of working with that on them, but we wanted to kind of expand this activity to a new location because of what we were hearing through our key informant interviews about, some of the communities that still weren't being reached by this activity. And so I'll go to the next slide, please. So it was through discussions with this other community-based organization, the Sidewalk Project, who are, a nonprofit that focus on harm reduction services in the Skid Row area and work with sex workers in that community. So they were, it was with the interview with this program where, it was really revealed to us that despite all the different programming that is focused downtown and on Skid Row, there were still, pockets and neighborhoods and communities that were still not being reached. And in particular, this community that were really high risk and experiencing a lot of syphilis at the time. So this team, the Sidewalk Project, were letting us know that a lot of the clients that they work with were being diagnosed with syphilis, but were having challenges getting the treatment that they need. And so we can go to the next slide. And so what we did is we brought Sidewalk Project, LA Christian together to plan and design a special testing event that took place in December in this area. So these pictures, the map shows you where we were. This is right in the area that the Sidewalk Project specializes in working with clients and communicates to us that there were a lot of cisgender women who do sex work that lived there and that would benefit from this work. So we, figured out a good area to try to do this project on a kind of a sidewalk area that had no storefront entrances there. And what we did was we worked with LA Christian as well so that they could be part of this program as well. And so that picture on the bottom right is their Sprinter van that they have and use for other outreach activities. They brought that, and we brought that bigger MTU unit to the event. And so we can go to the next slide. So this just shows you all of the different organizations that participated in all of the services that they were providing. So you can see it was, quite extensive what we pulled together for that day. So the van that was from our office really focused on the sexual health aspect of the work. And then the LA Christian van was there, what we called the wellness portion of the event. So they really, they were offering their point of care testing as well for folks who maybe didn't want venipuncture or, but our goal was to do the lab-based instrumented test that day for these clients. LA Christian was there also offering things like wound care, blood pressure checks, and linkage to their full scope services that they have at a brick and mortar clinic in the area. Sidewalk Project, I just really want to point out how important their participation was in this. So they, prior to the event, they promoted the event. They took, we created a flyer with them and they let everybody know in the area that this event was coming up. And then on the day of the event, they helped, do outreach or in the area to bring clients in and say, hey, this event's happening right now, is, come with me and we can go get those services we talked about. And they also continued to do their harm reduction and overdose prevention outreach at the time. They also brought in another partner, the LA Community Action Network, which who provided some holistic womb education that day. And then Housing for Health is another county agency that we work closely with, and they also provided some event support as well on this day. So really a lot going on, but really a lot of great partnerships. Can I go to the next slide? So we ended up on that day, we ended up serving testing 22 individuals on that day, and you can see some of the breakdown about who we served. You know, our goal, we did, you know, again, this project really was driven by, you know, the concerns about the rising rates of congenital syphilis. So we really did have a focus on cisgender women of childbearing age. We were able to, you know, serve 10 cisgender women that day. But I will say, which was about 50% of the clients served, but the group tended to be older than, you know, was our kind of priority population. You know, the other thing that happened on that day is there were a lot of folks who signed up who didn't end up getting testing or treatment that day. So about 16 individuals that were around, came, you know, engaged with the program. We had food, we had some incentives just for signing up, but didn't end up sticking around. And some of that had to do with some of the wait times and competing priorities that, you know, they were experiencing. So, you know, that was a big lesson learned, is that, you know, that there might be a lot of folks who come and go, and how can we potentially engage them so that, you know, we don't lose as many people the next time we are doing something like this. We also were able to treat 5 people that day, either because they presented as symptomatic, or we had a DIS staff person with us who was doing a case review in the system, in our surveillance system, and, you know, was able to see folks had a history of untreated syphilis. So those folks, we had a conversation and said, based on your history, we think, you know, you would benefit from treatment today, as well as a blood draw. So go into the next slide. So this slide just gives you some more data about our results. So we also did 3 Psych, Gonorrhea, and Chlamydia testing. And so really what you can see here is like very high positivity rates. If we're focusing on syphilis, you can see that, you know, we had, out of 21 tests performed, we had 9 positive results, which is a 43% positivity. 3 of those folks were serofast. So ultimately, we identified 5 new infections. So that was 24% of those tested. Another thing you'll note is, so our phlebotomist testers, they did an intake interview at the while they were, you know, doing the testing with clients. And so we also offered 3 Psych, Gonorrhea, and Chlamydia testing to folks. Even though we did have some folks who reported anal sex, receptive anal sex, we didn't end up getting any rectal swabs. So that's something that, you know, as a group, we're kind of looking into, whether it was not acceptable to clients, or we need to do more education for our staff around how to have discussions about anal sex and getting those tests done. But otherwise, the other thing about the 3 site testing that was a lesson learned and challenge is our bathroom on our MTU wasn't functional that day. So we ended up purchasing a porta potty to be on site that day. So clients had to, you know, leave the testing area to go to the porta potty to get the swab. So that may have been a hindrance to getting those tests performed. We'll go to the next slide. So as part of this activity, we knew we needed to do follow-up treatment for folks who had positive testing on that day, as well as for folks who needed, you know, the full 3-week series of Bicillin injections. So we had built that into the plan, that we would have at least 3 weeks of follow-up to the same area and community. So on those days, we had a much smaller crew. We went in one of our county vehicles, a little SUV, with myself. We had 2 nurses, because what we were trying to do is use this as an opportunity to train our staff to do this work, because this is definitely a newer activity for the folks who work in our office. Doing this kind of street outreach and doing these injections on the street is definitely new for our team. So each time we went out, we had one who had already had the experience doing it, and then one trainee. And then we also went out with our coordinator. Everything was in the back of the SUV, including, very importantly, those privacy screens, which you can see in the image there. We had an incentive program for this. Besides food and water, we also were giving a $50 gift card when the person did the shot. And I think that was very helpful in motivating folks to, remember to look out for us and to come find us on the return visits. And so you can see the injections and treatments that we were able to provide on those 3 follow-up days. And we can go to the next slide. So challenges, really one of the biggest challenges was managing that kind of waiting room environment on the street. That really seemed to contribute to us losing a few folks, because things just got a little bit chaotic at times. It was hard to, really organize that space, but, that's definitely a lesson learned that we're going to, think through for the next future events. Date and timing of the event, we were there pretty early. And so folks were still sleeping in some cases. We also were there at the beginning of the month, which we were informed by our partners that that's when a lot of sex workers tend to be more busy because folks have gotten their paychecks or their GR checks. And so there's more customers who have funding to be able to afford services. So we may have missed some folks for that reason. Obviously, we all experience the penicillin allergy issue. And for this population who are living on the street, being able to adhere with a, multi-week doxycycline, regimen is a challenge. And so there were some clients who we had to continue with that approach that we would love to do, to get them penicillin challenged, inpatient perhaps, so that we can, get them Bicillin injections instead. Local business owners got a little upset that we had such a large scale event in their area without notifying them in advance. So that's something we plan to change in the future and do more proactive outreach to the community before we do an event like that. And then the thing about the porta potties, as I explained, was a bit of a challenge. We'll go to the next slide. So just some of the successes, the community partnerships really were key. I can't speak highly enough about how important it was to both have LA Christian there with their experience doing this work in this area, and then Sidewalk Project, who really had, really we relied on them for their relationships, the trust that they had, and credibility in the community. They were essential with getting clients on the day of the event and then finding them, helping us find them in the follow-up events as well. And then, of course, the expanded services we were able to offer because of the different community partnerships. The DIS case history checks on site was really, really helpful. And I definitely think that cut a lot of barriers and time that might be going into intervening in these cases. And obviously incentives and food were really successful for engagement. So, again, a lot of lessons learned. One of the other things I just want to mention is this kind of idea for the next time. We might be thinking about doing a sort of a fast track approach, so to allow for priority patients to be seen more quickly. Again, in this case, we really wanted to focus on cisgender women of childbearing age. And, there was a lot of ways in which early on the event was very male dominated space. And so, again, we want to get those services to those folks as well. But when we had some of our priority patients coming up and then really long wait lines, we're thinking about figuring out a way to fast track those folks in, so that we can make sure that they get the services that they need. So I think that's it for us. This is all of our contact info, and I appreciate everybody's time today.
Fantastic. Thank you so much, Becca and Shobita. That was Such an amazing presentation and a great case study in how to leverage those community partnerships that I know we all hear about so often. So thank you so much for that. We're just going to continue right along so that we have time for all of our amazing presentations. So now I'm going to introduce our two speakers from Louisiana. Elizabeth Lindsay is the Perinatal Surveillance Supervisor for the Louisiana STD, HIV, and Hepatitis program. She's a trained epidemiologist and oversees all investigations related to congenital syphilis and perinatal HIV statewide, along with supervising the perinatal case management program. She believes that community input and education are both key to STI prevention. She graduated from Tulane University with her MPH in 2017 and has over 5 years of experience working directly with communities across Louisiana, especially those most affected by homophobia and systemic racism. And we also have Laurencia Gauguisha, who is a perinatal case manager in the southern region of Louisiana. She serves the women, infants, and families of South Louisiana who have been affected by syphilis. Laurencia believes that everyone can take control of their sexual and reproductive health, and that this is accomplished through equitable access, education, and resources. She has a nursing career that has spanned 15 years and a background in public health with an MPH and a concentration in global health. She graduated with her BSN in nursing in 2007 and her MPH in 2021, and is currently pursuing a master's in nursing with a concentration in bioinformatics. Welcome to both of you. And before you get started, I'll just remind folks to continue putting questions in the chat, and we'll get to them at the end of the presentations. So let me share my screen, and I'll pass it over to you.
Good afternoon, everyone. My name is Elizabeth Lindsay. I'm the Perinatal Surveillance Supervisor for Louisiana. Thank you to Talia and thank you to NCSD for giving us the chance to speak today. As stated, we'll be covering the state of congenital syphilis in Louisiana and interventions that have been put in place by our program. Next slide, please. Before we get into the data, I want to give everyone an overview of our state and the barriers that our clients face on a daily basis. It's important to note that Louisiana, for the most part, is largely rural. Our clients live in isolated areas where population density is low outside of major metropolitan areas such as New Orleans in southeast Louisiana and Baton Rouge, central Louisiana. These areas are often also designated as health professional shortage and low-income areas. While Medicaid expansion in 2016 helped over 400,000 residents gain access to medical insurance, these areas have limited or non-existent access to many specialties, including OBGYN care. In terms of transportation, many parts of our state have poor infrastructure, both city-provided services and Medicaid transportation, that does not accommodate those who do not have a reliable access to a car, and many do not have the financial means to seek care in other areas. Louisiana has an overall 19.2 poverty rate, along with the second highest income inequality in the U.S. All of this and more disproportionately affects our communities of color. 31.4% of Black Louisiana residents live below the poverty line. Next slide, please. With that in mind, our program has made considerable efforts to combat the spread of STIs and HIV in our state. In 2018, Louisiana was ranked in the top 5 across all STI HIV categories, with the highest being congenital syphilis at number 1. In 2019, Louisiana was able to achieve lower rankings for primary, secondary, and congenital syphilis. HIV also saw a reduction in the number of new diagnoses from 973 in 2018 to 881 in 2019. With regards to 2020, it's difficult to fully ascertain the impact that COVID had on the spread of STIs and HIV, but we did see a reduction in congenital syphilis cases, chlamydia, and HIV diagnoses. However, it's important to note that even with the impact of COVID-19 in 2020, we only had 5 fewer cases of congenital syphilis compared to 2019. Next slide, please. This graph displays Louisiana's congenital syphilis rate per 100,000 live births over the past 10 years. Since 2011, Louisiana's case rate has always been significantly higher than the one seen nationally. With exception to 2018, where we saw a reduction to 72.8, our rate has steadily increased over the years and peaked in 2019 at 111.4. For 2020, we did see a slight reduction to 108.6. However, this is only a slight decrease from the one seen in 2019, which again is notable given the large-scale impact of the COVID-19 pandemic. Next slide, please. As we explore this further, we can start to see the disparities across multiple levels. In 2020, 71% of our congenital syphilis cases occurred in 4 main regions: New Orleans, which is in Region 1, Alexandria, Region 6, Shreveport, Region 7, and Monroe, Region 8. It's important to note that Regions 6, 7, and 8 are largely rural, and many women in these areas have faced significant barriers in terms of access to care and reliable transportation. With regards to race, the majority of moms linked to a 2020 CS case were women of color. 79% were Black, 17% were white, and 4% were Hispanic or Latina. Age-wise, 76% of moms were under the age of 30 at delivery. If we look at the care continuum, we can also start to see missed opportunities where these cases could have been prevented. These moms were largely enthusiastic and willing to seek out prenatal care. 89% were able to have their first prenatal care visit at least 2 months before delivery. Among them, 32% did not receive a syphilis test at their first prenatal care visit, and 25% did not receive a third trimester syphilis test. As we all know, tests at both time points are critical, as this gives us ability to diagnose and adequately treat our moms within a timely manner that allows us to prevent future cases of congenital syphilis. Next slide, please. This table depicts much of the same data that we just covered, but it does display some additional info related to prenatal care and socioeconomic status during pregnancy. The American College of Obstetricians and Gynecologists recommends that pregnant women have at least 14 or more prenatal care visits before delivery. As we can see in the table, 40% of our affected moms had 8 or fewer visits during their pregnancy. Only 22% were able to have 14 or more as recommended. For this analysis, we used insurance to estimate socioeconomic status. While it is not a direct measure, it can help to determine areas with the greatest need for prevention. And as we can see, an overwhelming majority of moms, around 85%, linked to a 2020 congenital syphilis case, utilized government or public insurance during their pregnancy. Next slide, please. Louisiana was able to pass its first testing law in 2007, which requires that every physician attending to a pregnant woman was to offer an HIV and syphilis test at their first examination during their pregnancy. We also passed Act 459 in 2014, which expanded these requirements. It states that all pregnant women are to be offered opt-out syphilis and HIV testing at their first prenatal care visit, the first prenatal care visit in their third trimester, and at delivery. These were designed to prevent the missed opportunities that were outlined earlier with regard to syphilis testing. Next slide, please. Since then, we have been able to assess the effectiveness of these measures through data sharing agreements with our state Medicaid plans. This allows us to identify providers that may need additional education and support. Next slide, please. Our overall objective is to reduce the number of congenital syphilis cases by increasing access to appropriate syphilis treatment and utilize Medicaid syphilis testing of pregnant women to improve provider services. Our specific focus is on third trimester screening, as that has been identified as a major missed opportunity. Next slide, please. 2016 saw the establishment of our quarterly congenital syphilis case review boards, which occur in every OPH region. These are designed to identify and describe factors such as barriers, missed testing, among others, that may have contributed to the occurrence of a congenital syphilis case. Action items are also outlined for follow-up, which can consist of provider education and/or patient outreach. These review boards help instigate and strengthen collaboration between our central office here in New Orleans and our regional medical team leadership and disease intervention specialists. These meetings have continued every year since 2016 with a small hiatus in early 2020 due to the COVID-19 pandemic. This year also saw the creation of our regional STD HIV task forces for each OPH region. This allows our community partners to participate and discuss current regional issues affecting STI prevention in their area. And this has helped to increase STI HIV awareness and engagement in communities across the state. Next slide, please. For 2017 and 2018, our program was awarded supplemental funding through the CDC for our enhanced congenital syphilis response. This allowed us to design a perinatal case management program and hire 2 initial case managers, along with a CS nurse educator to promote provider awareness of LA screening, testing laws, and adherence to current recommended screening and treatment guidelines. In that year, we also hosted 2 CS conferences with support from the Denver Prevention Training Center in 2 high case morbidity areas. 2019 saw the update of our sanitary code, which now requires providers to send in negative results for reportable disease conditions, including HIV, hepatitis C, and syphilis. This allows for more accurate disease staging and treatment. And then coming to the present, we were able to expand our perinatal case management program to 2 additional regions, and we plan to expand that program statewide. Next slide, please. So getting a little bit more into our perinatal case management program, and it's really novel in its approach. It's currently located in central and northern Louisiana, so 4 regions total. Our perinatal case managers focus solely on women between 15 to 44 years of age who are living with syphilis, regardless of pregnancy status. So they could be pregnant or have the ability to be pregnant, with the objective of preventing future cases of congenital syphilis. Eligible clients must live in a region with a perinatal case manager and cannot be currently incarcerated. Once they are referred, our case managers meet with clients one-on-one and offer sexual and reproductive health education. This allows them to identify and address any resource needs, especially those that may affect a current pregnancy. And linking them to resources could look like linking them to prenatal care, to WIC, or the nurse-family partnership, which focuses on first-time moms. Our perinatal case managers connect with their clients as needed, at least once a month, and follow them to delivery. Through their efforts, our perinatal case managers have strengthened outreach efforts as far as HIV, PrEP, syphilis education, along with relationships with local providers and community-based agencies. Next slide, please. I will now hand things off to Laurencia, one of our perinatal case managers, who will speak more about our Bicillin delivery program.
Thank you so much, Liz. So thank you for the overview, and we talked about the problem and the overview of it, but now we want to go ahead and look at some of our interventions that we've implemented. In 2019, we implemented 2 interventions, the SHOT program, that's the Syphilis Home Observed Treatment Program, as well as the SHIP Direct RX program, and that's our Penicillin, our Bicillin delivery program. Both of these interventions were for women who were with untreated syphilis infections, who may not have been treated at the doctors for whatever reasons. Next slide, please. So the SHOT program, this is our Syphilis Home Observed Treatment Program. It was piloted in regions 4, 6, and 7. This is for pregnant women and their partners. And the project is now active in 4 regions in the state. The primary goal of this program was to increase access to appropriate treatment. Eligible patients, they met the following criteria, which was 1, no history of penicillin allergy. They must have access to working telephone landline or cellular service. They must live in an area with access to EMS and 911. This is for any pregnant women who must also have no complications in pregnancy, which would preclude treatment in the home. Home visits conducted by OPH nurses that are accompanied by disease investigation specialists and or the perinatal case managers. This has been a continued effort for Louisiana. And even though some of our regions have not had any SHOT program success as of now, and some of those reasons, and one major reason is for community engagement as well as provider awareness. And one major reason also is staff. So in the home, we have these shots are primarily given by OPH nurses that are usually housed in the health unit. So sometimes in areas, our clients are in some high crime areas. And, that has faced some resistance with some of our OPH staff. And we do have some solutions to that. One is increased awareness to your clients and to the community, first and foremost. Second is increased awareness to your providers. And third, and most important, is a solution with dedicated trained staff for SHOT-specific services. So this is taking dedicated staff from the OPH health units and saying, okay, this is what you're going to do. You guys are a special SHOT team, and whenever we need your services, we can deploy you. So I think another solution is thorough assessment of the home environment area prior to referral. And that's something that the case managers could definitely assist with. And although the Bicillin delivery program, it has been more effective than the SHOT program, I do believe that the SHOT has the potential to bypass that ineffectiveness if certain changes are made and implemented. Next slide, please. Some of our successes for the SHOT program have been increased treatment, adherence, and compliance. collaboration with our healthcare providers and our community partners as well, and cases averted of congenital syphilis. And in the year 2020, we had 60% of cases averted. Next slide, please. Some of our challenges were difficult to locate clients and establish contact. Sometimes we have clients who may not have phone numbers that are connected. We have clients that are also moved very often. Once again, not all staff were comfortable entering select neighborhoods where clients resided. And clients who are not eligible to receive home treatment, such as a penicillin allergy, who had no access to home phone service, or decreased availability to EMS in the area, and clients with complicated pregnancies. Next slide, please. Next is our SHIP Direct RX program, and this is to facilitate timely syphilis treatment by utilizing disease intervention specialists to deliver Bicillin to private OBGYN providers and community health centers that do not maintain medication on site. So I'm going to go ahead and discuss a case with that I have had success with SHIP Direct. We had a client who was living in a very rural area of the state. The facility was a very rural health clinic, and of course they did not house Bicillin due to high costs and shelf life. So what they did is they referred the client to us, to the OPH Health Unit. We went ahead and did an assessment of the overall situation. We got a referral and a prescription from that rural health provider, and we were able to deliver the Bicillin to that provider. The provider was able to administer the Bicillin not only to the client, but to the partner as well, all 3 series, and that was one of our cases. And it just showed a collaboration of community partners, provider education, and the success of the SHIP Direct program. Next slide, please. The SHIP Direct RX, it was implemented in October 2019 through a partnership with the Centers for Disease Control and Prevention. It was piloted in regions 4, 6, and 7, and this was limited to OB providers. This is now has been expanded statewide due to COVID-19 response. Medical providers are responsible for administering the injections, as well as assuring the patients are suitable candidates for Bicillin injections. What this does for the providers, and it's a big plus, is it lifts the burden of cost from the provider, since one dose of Bicillin is upwards of $1,500. And of course, with our pregnant clients, that is $1,500 times 3 doses. So far, 360 syringes of Bicillin have been provided through this program, and we have treated over 70 patients. Next slide, please. Some of the successes with the SHIP Direct RX program has been smooth and efficient process. We have not seen any issues with the providers. We have not had any complications or complaints. Also, an increased cooperation from community providers due to the removal of financial liability. That's a big one. We've also seen increased treatment accessibility for patients. Some of the challenges that we have seen has been some disagreement among providers over proper treatment protocol. So we have to constantly remind our providers of our sanitary code, as well as our CDC recommendations, as well as clients who may require multiple Bicillin doses. Next slide, please. Thank you to NCSD and acknowledgements to our great leadership. And if you have any questions, please put those in the chat. And our contact information is on the next slide. Thank you.
Thank you so much, Laurencia and Elizabeth. That was another fantastic presentation. So contact information is here. Feel free to put your email in the chat as well, so folks can copy it. And our last presenter today is Jeff Tobias from Diagnostics Direct. So we are very gracious to Diagnostics Direct. They have offered a donation of their Syphilis Health Check tests to NCSD to distribute to some of the attendees of this session today. So while Jeff is speaking, I'm going to put in the chat, we have a quick SurveyMonkey application for people that are interested in receiving a free donation of these tests that Jeff is going to speak about in a few moments. So I encourage you all to apply if you are interested. So I'm just going to quickly introduce Jeff and then I'll hand it over. So Jeff Tobias is the Vice President of Sales and Marketing at Diagnostics Direct, LLC. He has over 30 years of sales and marketing experience with 13 years in medical diagnostics. He is the co-founder and partner of Diagnostics Direct, LLC. All right, let me share my screen one last time. And Jeff, the floor is yours.
Thank you. Well, first of all, thanks for having me. And both presentations were fantastic. It's great to see, especially in the LA County, that seeing Syphilis Health Check used in that study. And so as a manufacturer, we rarely get to see the usage of the test where I'm really focused more on the selling and distribution side of it. So seeing how the tests are being used in your protocols is fantastic. I'm really here. I want to give you an overview for those people who are not familiar with Syphilis Health Check. Give you a quick overview on the test, how it works, and really open myself up. Like we said, we want to work with as many people as possible. So if there's a way to get involved with people who are not using it, that want to add it to their testing protocols, that's why I wanted to come in and make myself available today. So Talia, if you can just jump right to, I think it's slide 3 where I've got some bullet points. Back one more, right there. We have been around since 2010. We've got the CLIA waiver on the syphilis test in December of 2014. So we just crossed 7 years. We still to this day are the first and only CLIA waived rapid syphilis test in the United States. And in that time, in the 7 years, we've put millions of tests out into the medical community. We work with just about every type of medical outlet where you could do STD testing. The tonnage of our work is with state-run public health departments. But as you can see from the list here, we have pretty much penetrated anywhere and everywhere where you could do STD testing. And you can move on to the next. Right here, no, back one up. I wanted to just run, there's a video embedded in there, Talia. There's a 2-minute video. This is basically going to show you exactly how the test works. For those of you who are not familiar, this is also up on our website 24/7. The web address is at the bottom there. So you can always have this for your reference, but that should just be a 2-minute video. There we go.
To perform the Syphilis Health Check finger stick procedure, you should first organize all the materials needed. Then mark the test device with the patient's ID. Take the patient's hand and identify the finger stick location. Clean the area with alcohol and dry thoroughly. Make a puncture with the lancet and wipe away the first drop of blood with a sterile gauze pad. Massage the finger to obtain a full drop of blood, and collect by holding the disposable plastic fixed volume pipette horizontally and touching the tip of the pipette to the blood drop filling to the black line. Don't squeeze the bulb to collect the sample. Dispense the entire sample into the circular-shaped sample well by squeezing the bulb of the pipette, and be sure to dispense of all test and materials used in the procedure in a biohazard waste container. Allow the sample to absorb into the membrane before adding 4 drops of diluent into the sample well, making sure not to touch the tip of the diluent bottle to the membrane. Once the diluent has been added, set the timer for 10 minutes. Once 10 minutes has passed, the test result remains valid for an additional 5 minutes. A test device with a red sample well, red control line, and no test line indicates a negative result. A test device with a red sample well, red control line, and a red test line indicates a positive result. External quality control set is available and sold separately. For more information, contact Diagnostics Direct at 866-358-9282.
That's the end of it there, Tully. Thank you. So that's, I mean, that works pretty much in line with every other whole blood finger stick test. It's if you go to the next slide, please, Talia, I'll kind of go over a little bit of this. What you get from us, we sell them in boxes of 20. You get the pipettes and the diluent. You would have to provide your own lancets and alcohol wipe and gauze pad. It's a two-step test. It's 97.3% accurate, which means we have a small false positive rate, but nothing that's too difficult to overcome. 10 minutes to a result. Again, the window's reading it between 10 and 15 minutes. Our tests are good for 2 years from the day we make them, and we turn our inventory over about every 3 to 5 months. So just about everything going out of our facility has at least 18 months of shelf life, if not more. I have looked up the CPT codes for this year for those of you who are able to get reimbursed through insurance. 86780 with the QW CLIA waiver qualifier there is the code, and it is again 1324 reimbursement per test. And so at a average cost of $10 for the test, there is a small profit to be made for those who can get reimbursed through insurance. Next slide. So in terms of looking at this, since this was more of a field test, or we had some field testing going here, I wanted to talk a little bit about the tests themselves and the durability, and especially in a mobile setting. The bandwidth on our tests is pretty broad. They consider room temperature to be between 40 and 86 degrees. I can tell you that we've had some issues with the test in extreme heat and extreme cold. The most notable recently is the big Texas freeze, where they were like frozen solid for 10 days. The Texas Department of Health lost a lot of tests that just got frozen solid, and even though they thawed back out, those tests became damaged. And so understanding that you guys are maybe in some extreme cold weather places or extreme heat, we want to try to make sure that we're keeping the test within that 40 to 86 degrees. We don't want to leave them in any mobile units overnight. And if you're doing things outdoors, hopefully you're not having to do testing in below 40 or above 86 degree weather, but that can play on results. As it relates to controls, people always ask me all the time, what do you recommend? Everyone has their own control protocols they have to follow based on the certifications that they have. I've got some customers that run controls every day. I've got some customers that don't run them at all. I have everything in between. What we recommend in a mobile setting is that you are creating a new testing environment every time you go out. And so it would be wise to run controls at least once when you're setting up that testing environment. They are refrigerated until you're ready to use them. So typically you let them come out, warm up for about an hour, use them, and then put them back in the refrigerator. We recommend that you would use some sort of cooler if you're going to take them into a mobile setting. But the controls themselves are really highly stable. We stress tested them. They went 39 days at 113 degrees before they started to break down and have any issues. So again, the test in and of itself should be really geared for a mobile outreach program, as we've seen here in these presentations. So hopefully it's something that can continue to get incorporated throughout the country. Next slide, I think. Okay. The other thing I just wanted to end on, I don't know if you guys have been aware, and we are going to dedicate a page on our website to this. They are starting to see with COVID, the COVID vaccine is interfering with non-treponemal syphilis testing. Right now, it's just the Bioplex test. They are doing more studies. If you can go to the next slide, they are doing more studies on other non-treponemal tests. So far, treponemal seems to be unaffected. But with almost 200 million people that have had 2 COVID vaccine shots, they're starting to see, they're going to investigate this a little bit more. And I think there's a couple attachments where the FDA had made some announcements about this, but we're going to have a page on our website that's going to kind of follow this and track this so that we understand what's going on in the syphilis testing arena here. But as of right now, none of the treponemal tests seem to be affected. We're conducting our own studies. We've got COVID vaccinated blood with both syphilis infection and without, and so far our test is running as it should be to date. But this is something I just wanted to bring it to everyone's attention. There are a couple of publications from the FDA that they've put out that I've added as attachments that you can, they're here in the chat room. So that's pretty much all I have. This is kind of a Syphilis Health Check top line overview. Please feel free to reach out to me or to Talia if you're interested in learning more about Syphilis Health Check. We're always excited to work with more and more people, and we do a lot of work with the NCSD. They're great at getting the word out. We donate product to them several times a year, and so they're a great partner to have. And I've really enjoyed being a part of this today. Again, from the manufacturing side, we don't always get to see how you guys are tackling these issues, and so this has been really informative for me. So I appreciate it. Thank you.
Thank you so much, Jeff. And thank you to Diagnostics Direct. We're always so grateful for your donations and are really excited to offer that as part of our session today. So like I mentioned before, I put in the chat a few times the short application that we put together for attendees today. So feel free to fill that out. We're going to have that open for a week. So that will be due next Wednesday. It looks like most of the questions in the chat box have been answered by our lovely presenters. So thank you so much. Jeff, maybe put your contact information in the chat so that folks can reach out. So the last 25 or so minutes of today's session, we're going to go into breakout rooms again. So we have a few facilitated questions based off of what we heard in our presentations today. I also encourage you all to think through as a group how you might use some of these donated tests like Los Angeles has in their outreach program. Seeing that in action was really inspiring, and hopefully it will inspire you all for some programs that you can run in your own communities. So I'm going to get the breakout rooms ready and just give my NCSD colleagues a few moments to get situated in their breakout rooms.